Instead of picking up a shift in the emergency department, I work on a case 1 day a week. It's just something a bit different to kind of broaden and round out the whole nurse that I am.
And how did you go about finding your first client?
Create a website and join a listserv and said, there you go. You have the tools you need. You have the judgment and the clinical skills. I think you'll do just fine.
Hello and welcome back to On the Stand with Ashish Arun, the podcast where we explore the law, practice and business of expert witness testimony. Today, we are joined by Marilyn McCullum, a triple board certified emergency and trauma nurse expert witness who brings a truly unique perspective to legal cases. Marilyn holds certifications as a certified emergency nurse, certified pediatric emergency nurse, and trauma certified registered nurse, credentials that put her in rare company among nursing experts. What sets her apart is that she still works clinically 32 hours a week while running her expert witness practice, giving her current hands-on experience that many experts lack. She is also bilingual in English and Spanish, an increasingly valuable skill in today's diverse healthcare landscape. She's an award-winning, internationally published author whose article on fall risk prevention won Article of the Year from the Journal of Legal Nurse Consulting. Most recently, her work on emergency department patient flows earned Editor's Choice in RCNI's Emergency Nurse, a leading UK nursing journal. She's also been published in the American Journal of Nursing, Law 360, and the Bar Journal, writing on topics ranging from triage assessment to documentation bias to criminal nursing cases. She's a frequent speaker at CEU, CME, and CLE conferences and contracts as a subject matter expert for HealthStream, developing education for healthcare professionals nationwide. Perhaps most interesting for our conversation today, though, is that Marilyn recently made the bold decision to obtain dual licensure in both California and New Zealand, expanding her practice internationally. So let's ask Marilyn all about these different things that she's done and what else is on her plate these days. So Marilyn, welcome to the stand.
Thank you for having me.
It's a pleasure to have you here. I know we've been talking on LinkedIn about doing this for a long time, and we've finally gotten together today to record this. So you've been an ER nurse since 2011, and you started your expert witness practice in 2019. So what sparked that transition? Was there a specific case or moment that made you think that I could probably help attorneys understand this?
No, actually, I fell into it by accident. I was living in California at the time and wanted to go visit my mom in Indiana with a brand new baby that we had just had a few months ago. And so I found a cool conference, looked interesting. It was called the American Association of Legal Nurse Consultants in Louisville, Kentucky. And so I went, didn't know a single thing about legal nurse consulting. I sat down at the table, and it happened to be with the president and vice president of the AALNC at the time. And so that was my introduction to the AALNC. We started talking. They were so nice, so helpful. They were not judgmental at all when they learned that I had zero experience in the field. And they gave me that curiosity to want to learn more and see what they did from their side of nursing and not just bedside. And so that's what kind of sparked the transition.
That's interesting. I mean, that is one thing even I have noticed about legal nursing, like the LNC community, even on LinkedIn, that they're all very supportive of each other. Even with the new nurses who are trying to break into legal nurse consulting, and there are these seasoned nurses who are always out there trying to help, answer questions, share their experiences. So, I mean, I completely understand, and it makes sense that that was your experience as well when you went to the AALNC conference. So what did those early cases look like? And how did you go about finding your first clients? Because that's another question we keep seeing LNCs asking.
So the first cases, I don't remember exactly how I fell into it. It was around 2020 when I got my first expert nurse case, and I had a mentor at the time. She's a wonderful nurse from New York City, and we had scheduled a few conference calls. And then I remember at one call, I called her and she was just in tears because she had just lost one of her friends to COVID. And so it just struck me that wow, this woman is in such emotional distress right now, but she's still taking the time out to mentor me and go through this process with me. This must be something she feels really strongly about. And so under her guidance, she gave me a case to work on, to practice on. And then kind of sent me off into the world with that and instructions to create a website and join a listserv, and said, here you go. You have the tools you need. You have the judgment and the clinical skills. I think you'll do just fine. And surprisingly, I was very pleased.
But you still manage to work like more than 30 hours a week. And this is something that I have seen that a lot of LNCs, they stop clinical practice. But you still do both. So why is staying active at the bedside so important to your credibility as an expert? Is it important? And how do opposing counsel react when they learn that you're not just an expert who used to practice, but who was probably in the ER last week?
Right. Yes, what I always say in depositions is I'm first and foremost an emergency room nurse. The expert stuff is something that I do on the side, and so some attorneys try to bring in the hired gun angle, and for me, that's very easy to circumvent because my primary job is being an ED nurse. That's what I do. It's what I know. It's what I'm comfortable with, and it's what I love. And I have found using the expert side business that I have, that is kind of teaching moments, not only for other people, but also for myself, just to tweak certain issues or considerations in my clinical practice. It also helps me when I'm teaching new nurses in my department. I can use those sort of cases and say, oh, by the way, always make sure you prime an IV line, because if you don't, XYZ can happen. It sounds crazy, but it does happen. And so having those real life cases to kind of back up the teaching moments with the younger nurses really helps them and opens their eyes a bit more. I think there's places for both types of experts, the full-time experts who do that as their sole income, and then also experts like me who our full-time job or our complete job is ED nursing, and we just like to expand on that. Instead of picking up a shift in the emergency department, I work on a case one day a week. And it's just something a bit different to kind of broaden and round out the whole nurse that I am.
So a lot of LNCs would also only do pre-litigation medical record review, and they would not do testifying work. Like they are not a testifying expert. They are primarily a consulting pre-litigation review nurse. So it's clear that you are the testifying expert. But if an attorney comes up to you and says, hey, I don't need you as a testifying expert, but there are these medical records on these cases and I need you to review them for merit. So do you take those assignments as well, or you only come in when it's a case where they need a testifying expert?
So I'm only contracted as an expert. I have received phone calls similar to what you're describing, saying, hey, I need you to take a look at this and see if there's breach or if the nurses were doing a fine job. But I go into that with the understanding and assumption that I'm looking at this as an expert with potential to be the testifying expert if their case can be supported and if they choose to move on with that case. But I don't do kind of behind the scenes. I know several LNCs who do different levels of that. I don't do that. I offer just the expert testimony, expert work.
Yeah, no, that's perfectly understandable. I mean, everybody has their own set of skills that like a lot of experts are not comfortable maybe being deposed. So for them, I think just staying behind the scenes and not having to being grilled, cross-examined, or like you said, that opposing counsels would bring in the whole hired gun thing. So maybe a lot of people are not, either they're not able to handle it or they just don't want to handle it.
Or maybe they're just scared, but I grew up in the ED. I've been in the ED for 20 years because I started for 5 years as a tech. And so that was back in the day when we had paper charting on the little clipboards and we had a few honorary grumpy doctors. And so I've had clipboards hurled at my head before. if I can survive that from a doctor, I can survive a deposition with an attorney. So it doesn't make me apprehensive or worried or scared
Mhm.
uh, going in front of an attorney for deposition. And when I'm telling my kids, when they ask me, "Hey, mommy, what are you doing today?" My answer is always, "I'm going to go help some attorneys understand what mommy's job is and how these nurses were doing their job."
Today's episode of On the Stand is brought to you by Xlightum, the AI-powered platform where attorneys find expert witnesses and experts grow their practice. Every week, hundreds of new experts join Xlightum, giving attorneys instant access to qualified witnesses without any finder's fee or markups. Need someone else to handle the vetting? Our concierge service does it all. You only pay when you retain an expert we present. So whether you are searching yourself or letting us do the heavy lifting, Xlightum makes expert discovery fast and smarter. Visit Xlightum, that's exlitem.com, to find your next expert witness today. So you're triple board certified. Now this is interesting. Like you have a CEN, CPEN, and TCRN. And for attorneys listening who may not know the difference, what are these certifications and when does it matter in a case? Like how do you explain to attorneys why they might need a pediatric emergency expert versus a general ER expert? Can you talk a little about that?
Yeah, so the board certifications, they're similar fashion to physicians who are board certified.
Mm-hmm.
So it is a test, national test that you sit for, just as a physician would sit for theirs. And the ones that I have are the CEN, which is the Certified Emergency Nurse. I have the CPEN, which is the Certified Pediatrics Emergency Nurse. And then I also have the TCRN, which is the Trauma Certified Registered Nurse. I have looked up and actually reached out to the BCEN to figure out how many nurses are triple board certified, and
Mm-hmm.
they don't have the actual numbers, but they said it's very small. So I know several nurses who have sat for the CEN, and we all say that that is one of the toughest tests that we've had to take. I'm a great test taker, and it made me cry. And maybe because I was 7 months pregnant at the time, but regardless, I passed it. So I'm very happy for that. But the certifications represent kind of going a little bit above and beyond general bedside nursing. When you see a nurse that has a board certification, that should signify to the person viewing this nurse that this nurse takes their job very seriously. They've gone above and beyond just learning their department. They've learned national standards and national care for patients, and they've willingly sat for a very difficult test to obtain that certification to demonstrate that knowledge.
So, Madeline, that's really helpful. And I want to talk to you about fall risk prevention because in the hospital setting, falls are basically a key reason why hospitals get sued. And you've written an article that won Article of the Year for your piece on fall risk prevention. So, what are some of the most common gaps that you see in hospital fall prevention that lead to cases?
So it is just general standard of care that every patient in the emergency department who walks in should receive a fall risk screen of some
Okay.
sort. There's various screens out there. It kind of depends on the facility, which one the nurse is using, but a fall risk screen of some sort should be documented. So that is the first thing that I look at. The second issue or topic that I look at in the chart is what the results were of the screen and then implementation. Because it's all well and good to click through a few boxes to do your screen, but then I want to see, did the nurse do anything about that? Once they've indicated that this person is a high risk for falls, what steps did they take using their nursing judgment and the tools that are available to them? What steps did they take to implement these fall preventions? And that also is super quick to document in most computer systems. It takes maybe 30 seconds, if that. But I do notice that that is lacking quite a bit. And And it doesn't necessarily mean that they didn't do it, but unfortunately, it is tougher for me to defend when that particular bit isn't there.
But then, are there any clear red flags that when you are reviewing the record? Because one thing I keep hearing about and reading about is that now that the documentation has gone electronic, it's very easy to over document.
Mm-hmm.
Because now you have to check like a few boxes and hit save, and it looks like you have checked, and it's very easy to check them without reading, and it also leads to defensive documentation that yes, everything was done. So are there any red flags that tell you that okay, maybe this is defensive documentation and maybe they have checked but they haven't really followed the protocols?
I always look at timestamps.
Okay.
With electronic documentation, that's usually pretty easy, and I don't even need to get an audit report. Most of the time, it's just there in the documentation. I can see, for example, yes, it's documented at 4 a.m. in the morning, but the nurse may have done it at 7 a.m.
Yeah.
So while that does happen, that type of clustered charting, it's not recommended. And the reason being is because it's very easy for someone like me or an attorney to look at that charting and say, oh, did you actually do that at 4? Or did you just sit at the end of your shift and complete all of the required type of documentation?
Mm-hmm.
So I recommend to all nurses to document as contemporaneously as they can.
And about the audit trail report, you mentioned that you don't always ask for the audit trail because the timestamps are pretty revealing most of the times. What are some of the cases where attorneys and experts should ask for the audit trail?
Anytime there's a question about time documented versus when it was done.
Okay.
Some charts or files that I receive, it's very easy to see that. Other times it's not. I actually just spoke with a colleague earlier today about that, and we were talking about a stroke medication, and the way that the documentation printed out for this colleague was not showing when the infusion was started. And so he had asked for an audit, and that audit gave a lot more information for them.
Okay. And you've written about stroke management in the ER using the emergency severity index, where you've said time is brain. So walk us through what a legal nurse consultant looks for when evaluating whether stroke protocols were followed.
So I always ask in stroke cases for the hospital policy, even if it's just a verbal from the attorneys, because it varies. For example, if a nurse can call a stroke alert or if it has to be a physician or a provider. So that is like big topic, big thing, number one, who can call the stroke alert? And so that is the number one thing that I ask for my attorneys. And then the number two thing is going through those times. When did they arrive? When did the doctor/nurse first see them? When was the code stroke identified? Sometimes this happens before the patient even arrives if they're coming in via EMS. And then also, when did they go to CT? Because the goal is to get them as quick as you can. And at this point, they've just changed the guidelines to you don't even wait for blood to get them over to the CT scanner. IVs, blood, all of that can wait. We need to get a picture of that brain to determine if it's a bleed first. An IV really only takes a couple of seconds to place once they've returned to the room. And then from there, I kind of just follow through the general AHA stroke guidelines to see what was met and what wasn't met, especially if an antiplatelet was given. From there, I would need to look at the NIH stroke scales, which I have been involved in cases where nurses just didn't do them, and that is not standard of care. Our nurses should be doing their own stroke scales, even though a doctor does it as well.
That's really helpful. And so let's go to your the latest article that you wrote on ED patient flows. And it earned you the editor's choice in RCNI's Emergency Nurse, which is a leading UK journal, so congratulations for that. And it makes you an internationally published author. So what was it about ED flow management that you felt needed a closer look? And how does the way UK readers received it compare to the US conversation?
So the ED flow article was actually started while I was still working in California. So I have worked, because I used to be a travel nurse, before it got popular and paid well. I worked as a travel nurse, and so I've been in somewhere 14, 15 different emergency departments and across the United States. And generally, the flow is a patient comes in, they see a registration clerk, they sign in, then they see a nurse, get triaged, then they sit and they wait for a room. Occasionally, you'll have a provider in triage that may see the patients, write some orders. Then people started initiating vertical pathways or lean pathways in triage, which is a way to address the non-critical patients. If you know anything about ESI levels, it would be your ESI 4s and 5s. However, we were noticing that the sicker patients, the ESI 3s and the ESI 2s, were sitting for longer in the waiting room than these non-urgent patients who come in with an ortho complaint. And that just didn't make sense. And so then what they implemented at the hospital that I used to work at in California was they had a very unique portal system where the process is supposed to be, depending on how busy it is, the patient gets triaged and then they go into one of 4 portal rooms where they see a provider. There's a dedicated nurse that's assigned to these portal rooms, as well as a dedicated tech who's able to draw blood. So they're seen by the provider, the orders are placed, medications can get given, an IV may be started, radiology orders can be placed, blood can get started, and then depending on that, the emergency department provider decides this patient needs to go back to the main emergency department, or this patient is safe to wait in the lobby until we get some results back. And if it's all clear, we can arrange for disposition at that point. So that portal process really cut down on the door to provider times. The interesting thing with the portal flow compared to the lean or the vertical flow is that it also included the ESI2 patients. I go, obviously into great depth about this in my article, but I just found it so interesting that I had to write about it, and because it is my passion. Nobody likes to see patients, especially the sick patients, sitting there waiting in the emergency department with no care. And to see this very unique system put into place that works was really astounding.
This is interesting. So one, we will definitely circle back in a few months and see, because this, I think, is a subject that really needs more conversation across the world. It's not just a US or a UK or a New Zealand thing, because ED, I mean, whatever little I have seen in a few countries in the developing world, they are in like a worse shape. So clearly, this is something that I would encourage you to also probably take to conferences and talk as much about it as you can, because this is something that the world really needs, a better ED flow.
Good tip. I've been invited to a conference to speak about whatever I wish in 2027, and so maybe that one will be a good topic.
Yeah. So let's go a little back. I know we talked about documentation and defensive documentation earlier, but I want to ask you a couple of follow-up questions on that. You wrote an article called "When Words Wound," and it addressed stigmatizing language in electronic health records. So talk a little about that. Like, what kind of language are you seeing, and what do you mean by stigmatizing language in electronic health records?
So stigmatizing language, when I talk about that, is language that's meant or used in such a way to kind of separate or identify the patient or the person that you're writing about as other than. So can that happen? That can happen in a million different ways, obviously. So you have race and gender, socioeconomic norm, religion, just a million different ways that a writer can identify the patient as other than. What I see most commonly, though, is when unnecessary adjectives and unnecessary quotations are being used in charting. And so it's interesting because I've taught for a couple of groups of nursing students about documentation, and I actually have gotten feedback from one of the instructors saying they were going to redo their documentation portion based on what I discussed with them, what I talked about, because they were teaching put everything in quotations. Everything that the patient says, put it in quotations because that's their words. You want the chart to come across as true. And yes, I agree with that to a point. My question for the writer, the nurse, the physician, whoever it is that's putting this documentation in a legal record, ask what the purpose is for that entry. It's just to show that the patient can use a bunch of expletives and come up with creative insults. Is it necessary? Can you reword that in a more neutral language? Because if you can, I recommend that. It makes our nursing staff look better, and the patient, this chart is going to follow them for years because it's electronic. Everything's all tied together anymore. And that stigmatizing language, maybe a person had a hard day 2 years ago. They're coming to me in the emergency department. I see from their documentation that they were belligerent and saying a million different expletives, coming up with insults. Before I meet the patient, I already have a preconceived notion about them, which is going to directly impact how I interact with them the very first time we speak. And so I caution all nurses, all providers to use the most neutral documentation language that you can. While it's fun to come up with interesting things saying, oh, the patient said their taint hurt, it's not necessary.
And do you think this can actually strengthen a plaintiff's case if it comes to that? Like, can this biased documentation that uses stigmatizing language, can it actually strengthen a plaintiff's case if this eventually goes to court?
I worked on a plaintiff case where I was specifically called to do a report just on the biased language because the way they documented about this female patient was beyond the norm. And obviously she had had a bad outcome, otherwise there wouldn't be no case, right? But we were able to take that biased documentation from, I think it was 1 or 2 individuals in specific, and I wrote a report on that and correlated that to the poor treatment that she received while she was assigned under their care.
So how does this compare? You also talk about something called defensive documentation, and we talked about that. So on one hand, there is okay, I mean, I don't know if this can be categorized as defensive documentation. Let's just write whatever the patient is saying and put them in quotes so that at least tomorrow, if it goes to trial, if there's a case, it's there that these are not our words, this is how the patient was. So can this be a bad example of defensive documentation? That's one. And secondly, if that is the case, then what's the difference between good documentation, defensive documentation, and bad defensive documentation?
So I talk about documentation. I have like a 2-hour presentation that I do on it regarding good documentation, defensive, and then just terrible documentation examples, which are always fun to see the reactions on that. Good documentation is neutral. It's clear. It follows a timeline, and it tells a story. I want to know, as a behind-the-scenes reader, as an expert, when I look at the chart, I want to be able to look at that chart and know what happened to this patient while they were in the emergency department. Defensive documentation is it's similar to defensive driving. You can be a good driver, a defensive driver, You don't have to go to any crazy extremes. You're just aware when you're documenting that attorneys and other experts and potentially a judge and jury may be reading your documentation. That's just another reason to document professionally. So that's why I encourage neutral documentation, strong language, instead of just putting everything in quotes because it's maybe a little funny and that's what the patient said. Use nursing judgment and just tell the story of that patient as a professional.
Mm-hmm.
And then bad documentation, that's just documentation that says, unfortunately, it may bring up color. It may bring up some slurs, which I have seen, unfortunately, and it may bring up some illiterate type of quotation, which are unnecessary, and it's just showing the subsequent readers that this patient is ignorant or illiterate or lower educated. And that serves no purpose from a professional standpoint.
Let's talk a little bit about, like you said, that while documenting, you have to keep in mind that it can be looked at by an attorney at some point in time. And you work for both plaintiff and the defense.
Yes.
So, talking about working with attorneys, you also talked about that in depositions, the opposing counsel would usually bring out the whole hired gun narrative and try to paint you with that brush. So, one, how do you maintain neutrality when you're working with the plaintiff and the defense on different cases? And do attorneys ever push back when your opinion doesn't go their way? How do you deal with that?
Yeah. So for me, I don't find it too terrible to maintain neutrality. For example, on my testimony list, I have testimony for both plaintiff and defense for stroke patients. And that has been brought up in subsequent depositions. And how can you support the defense for this stroke patient, but the plaintiff for this one? And my response is always, I'm just looking for the standard of care. That's my goal. And in this particular instance, they met it. And in this one, they didn't. And so I don't work for a side. What I work for is healthcare standards. And I just want to maintain the professionalism of nursing and the professionalism of the medical world kind of in general. And that's how it's easy for me to maintain the neutrality because I'm not trying to please anybody. Attorneys, unfortunately, they have their job and they unfortunately may not like what I have to say, but more often than not, it's rare that I get pushback. Most of the time it's, oh, thank you, I hadn't thought of it like that. Are you sure XYZ shouldn't have happened? And once I explain the steps, then they're grateful that the case can stop there instead of going on 6 more paces before they realize what I just told them on the phone.
That's interesting because a lot of experts are attacked to be hired guns, and then attorneys would basically try and say that, oh, you do this for money. But so how do you tackle that attack? Because like I understand that that's not what a hired gun is. Like experts need to be paid for their opinion, and offering your opinion, and you're actually being paid for your time, not your opinion. Your opinion is not for sale. So how do you tackle these accusations when they are made during deposition in a live setting?
So for me, being an expert is not about money or notoriety, fame, whatever. It's teaching. It's maintaining that professionalism in my field, which is nursing, and particularly emergency department nursing. We all went to school for nursing. We all, for whatever reason, decided that we wanted to dedicate our lives to help other people. And so the standards exist for a reason. And most of the time, nurses do not wake up and say, I want to hurt somebody today. And so if I can look at a chart and help figure out and piece out certain things and really determine, was this a true breach or was this just maybe sloppy charting?
Mm-hmm.
I'm happy to do that. My goal, though, is education and teaching. Education for myself, but also for the future generation, because I do use it as when I'm a mentor for the younger nurses as well.
Mm-hmm. So that's actually a great segue to another article that you wrote, when nurses go criminal, because you said that, and I understand and agree that no nurses are waking up and saying, hey, I want to hurt somebody today. But you did write an article on when nurses go criminal, and I think it also touched upon the Arunda Watt case. So what prompted that piece? And how are criminal nursing cases different from civil malpractice cases? Like, what makes a malpractice criminal for a nurse?
So that piece, I believe that was around the time Redonda Vought case had come up.
Yeah.
And I'm part of a few listservs as well, and some people were saying how they've been involved in criminal cases, not just medical malpractice civil cases. And so there was a lot of confusion, even among the LNC world, on how that could. And so I kind of wrote that piece to just illustrate to not just attorneys, but also to nurses who may read that, to say your world isn't as small as you think it is. Kind of as I do with bedside nurses, like your world isn't just inside the hospital. There's so much that you can do as a nurse. And if you decide to do legal nurse work, if it's consulting or expert work, you can look at criminal cases. Redonda Vought did not wake up that morning and say that she wanted to hurt a patient. There's a lot behind that story. Her and I actually had a conversation about it in Louisville, Kentucky when I met her. She's wonderful, and it's a terrible teaching lesson that happened to her in Tennessee. But I believe that case really changed the landscape for nursing in general, to open their eyes and just go back to the basics. You pull a med out of an automated machine. We all want to trust that that's the right medication, but look at it, confirm it, read the bottle, just go back to the basics.
And would you say that because nurses are also under a lot of pressure, like somebody's life is at stake, somebody has to be administered, like especially in the ER, where, like a few seconds can be the difference between if somebody is going to go back from the hospital to their home or they'll go to the morgue. So would you feel that because there's so much pressure and because the time constraints are so strong, nurses can make mistakes in that setting? And for the same reason, they also need to be more careful?
It's a dichotomy, right? I mean, mistakes, but be careful. You have to have what's called just culture. And Redonda thought that she was participating in just culture by reporting her mistake as soon as she realized that it happened. I have known many nurses to make medication errors. Some are more severe than others. Some are just near misses, which are fortunate. But just culture in nursing is that culture, or the ability to recognize that this mistake has been made and then be able to talk about it and discuss it and figure out what contributed to making that mistake and how we can work as a group, as a department, to prevent that mistake from happening again. In Ms. Vought's case, the Pyxis machine was on override, for example. But I worked with another nurse, and we actually used her case within our department in a semi-annual meeting. We used her case to discuss her medication error and how we could learn from it, and we opened the floor to the audience to receive input on what would better help to prevent the same mistake from being made.
Mhm.
And so being able to take these mistakes, because we're all human, right? Being able to take these mistakes and turn them into a teaching moment and a moment that we can learn and change and adjust accordingly rather than punitive is so important. And I feel that Ms. Vaught just didn't get her chance, unfortunately, to do that.
Let's talk a little about the recent move that you've made. And you did say that you are a rare species where you are triple board certified. But I think the rarity even goes up when you are now dual licensed in California and New Zealand.
Yes.
And you told me in an earlier conversation that this was your first trip to New Zealand when you moved. So let's talk a little bit about that. Like when you moved, what was the process like to get licensed in New Zealand as an American nurse?
One of the reasons that I chose New Zealand, apart from the fact that it's beautiful, is the licensing process. I had looked at several other countries when we were looking at moving the kids, and other countries such as Canada, they require additional classes or tests for U.S. trained nurses. New Zealand only requires verification, and it was a little cumbersome as far as paperwork. Submitting all of that, I had to go back ages and find transcripts from college way back in the day, but I got everything together, and it actually didn't take that long to get verified. And so once they verified me, then they said, okay, apply for a New Zealand nurse license. And I did, and I got that within 48 hours. It was very quick. And once I had my APC, which is the New Zealand nurse license, I was able to apply for jobs. And I did that while I was working in California. And I applied for a job. It was Sunday night at around 8 p.m. and then I went out to run an errand, and I was on my way home at around 8:20. I received a phone call from a private number, and I answer it, and there is this very chipper, awake female talking in a heavily accented voice that I could barely understand about the job that I had just applied to. And she's my ED director now, Charlie. She's wonderful. But it was, for me, easy. Everything just kind of fell into place when it needed to very quickly, much quicker than anticipated. And then at that point, I just felt like I have to do this. There's something in the universe that's, why else would it be so easy? And so there's something in the universe that's telling me you need to do this. And so I did it. I made the jump all the way to the other side of the world.
Oh, yeah.
And it's wonderful. It's so similar, but so different, because U.S. is privatized healthcare, and New Zealand is socialized. It's publicly funded. And so one of my first days touring the emergency department, they're showing me the triage area and registration and all of that. And I asked the nurse, I'm like, so how do they determine copays here? And she just looked at me with this, and she's like, it's free. So little things like that were different and kind of humbling to a veteran ED nurse who all of a sudden realizes I don't know as much as I thought I did because I'm in a brand new environment. It was very interesting to learn the idiosyncrasies of the differences between the two types of healthcare. The general nursing, though, is very similar. Protocols are protocols. And as someone told me when I moved over here, a heart attack is a heart attack. We're going to treat it the same whether it's in California or China or New Zealand.
Yeah. But on the ground, are you seeing differences in the way people are approaching patients in the emergency room? And I know it's not been long, but have you implemented some of the learnings from the US healthcare system into the New Zealand healthcare system, or do you see scope for improvements to bring in from there, or the other way around? Like, what's your initial take on that? I know it's been like it's not been that long to have a very concrete opinion on that, but anything that you have on mind.
Yeah, it's very different. Biggest thing, because I talk about it so much in the United States, is documentation.
Yeah.
So New Zealand doesn't have medical malpractice. They actually have something called the ACC, where if anybody has an accident in New Zealand, it's covered. There's
Okay.
no pointing fingers and he said, she said, and I don't sue you for a car accident. It's just covered. So that part blew my mind to find out. And
Mm-hmm.
then the documentation in general, it's a lot more narrative. The facility that I work for, they do have computerized charting, which not all facilities do. A lot of them still have paper charting, especially in the South Island, but I'm in the
Mm-hmm.
North Island in the capital in Wellington.
Okay.
So we have computerized charting, but it's a lot more narrative charting. It's not like your epic point and click boxes that kind of guide you through the systems. It's more recall. So
Mm-hmm.
remembering, and we literally go through A, B, C, D, E, and F. Which we all learn about is in nursing school and in ACLS, PALS, all of those courses, your airway, your breathing, your circulation. But the way that we document at the facility that I work at is we're literally typing in A, documenting the airway in narrative form. But it's definitely a lot more relaxed because medical
Mm-hmm.
malpractice does not exist here. And so, for example, the other day I saw a piece of documentation that I would never see in the United States. And it was from a doctor, and it said that a malfunction caused the near death of this patient in the patient's chart. And you would never see something like that in the United States because that just screams liability
Mm-hmm.
on the hospital. And so that just kind of took me aback.
Yeah.
But it's not punitive here. You don't have attorneys breathing down your neck, and nurses can just document for the patient's benefit, for that
Mm-hmm.
continuity of care. Because when I teach about documentation, what I teach is we're documenting not only for continuity of care, but we're documenting for insurance purposes, billing
Yeah.
purposes, and potential litigation.
Yeah.
And so in New Zealand, you take away those three things, and documentation is a lot more relaxed.
Mm-hmm. Again, I mean, I'm not really sure if one can really pick and choose that, okay, one system's better than the other. I'm sure they both have their pros and cons.
Yeah.
And but how does it work from a practical standpoint? Like, again, I mean, you're continuing your expert witness practice. So while being in New Zealand, you're still reviewing cases and you're still acting as expert on cases in the US because the move doesn't evaporate your qualifications and experience. And there's technology to help you handle, but you're still human at the end of the day. At least I'd like to believe that. And so, how do you juggle the time zones? Because time difference between New Zealand and California.
I think in California it's 18 hours time.
Wow.
So I always say I'm living in the future because it's
Yeah.
the next day for me.
Yeah. So is that an advantage? But also given the time difference, and you have a day job in New Zealand, so it's not that you're sleeping all day and then you're working all night. So how do you manage it?
So it's actually not been too difficult for me to transition. It's really great being a day ahead because when I
Mhm.
tell my attorney clients that I'll have something for them by the end of next week, they get something on Thursday, which is my Friday. So they think they get it a day ahead of time, um, instead of at the last minute. And so that is helpful for me.
Mhm.
As far as organizing my time, found that it's not too bad. I did switch to night shift here in New Zealand,
Okay.
and so I work until 7 in the morning. Um, And then I have 3 kids, so I send the kids off to school, and then I still have that morning gap, which is afternoon in most of the United States, to
Hmm.
catch up on emails, make some phone calls, and just kind of tidy up the workload. And then I do the bulk of my legal expert work on my days off. And that's actually been working really well. I used to do morning depositions. I still do morning for me depositions, but it's afternoon in the United States. And so sometimes some attorneys do have some cutoff times that they may not be as thrilled with, uh, had it been morning. Yeah, it's worked out very well, especially
Hmm.
me transitioning to night shift and being able to take my 3 a.m. lunch break and make a few phone calls in the States, which is around 8 a.m. in California time. Um, it's worked out very well.
Mm. So, would you recommend other legal nurses who may be doing expert witness work to consider an international move? Like what are a few things that you would want them to think through before they make the jump?
So think through. I would recommend that they have a strong background in the United States first. Because there are quite a few experts, and I've found in the past few years there have been even more people trying to break into the field and be experts, and legal nurse consultants, get away from the bedside kind of deal. But I would recommend have something that other people don't have. For example, I've got 3 board certifications. I've got 2 pages of publications on my CV and another 2 pages of presentations that I do. So
Hmm.
make it worth if you're going to move and be international, make yourself invaluable or make it so that you have something to offer that they can't get from somebody 2 states over. Another thing I would caution is looking at the travel portion of your fee schedule. I know a lot of experts like to charge door-to-door rates and all of that, and I have found that I don't think it's fair for them to pay for my time for an 18-hour flight. Um,
Yeah.
Paying for the flight is fair enough. But as far as the time, that is very minimal. Really, it's just the time worked on the case.
Hmm.
And also consider still working in your field because while attorneys are okay with me being in New Zealand because so much is remote these days and so few
Yeah.
cases actually go to trial. They're okay with me being in New Zealand, but that key factor that they want is, are you still working in an emergency department? So I can still say yes. So, but for another nurse who's considering maybe moving somewhere else, look at that and see if you can maybe stay in your field.
Hmm.
Because I've looked at expert qualifications in several states and it says must be working in that department, but it doesn't specify what country.
Yeah. Interesting. So clearly, certification is something that's important, and it always helps. What are some of the other things that somebody who's probably interested in becoming a legal nurse consultant or an expert witness, and we won't get into whether it is to leave the bedside or otherwise, but just to get started, what's the first step or the first few steps that they should take? What advice are you giving to new nurses who want to explore this field?
So, what I have noticed in social media and nursing
Hmm.
groups in general, people want to be a legal nurse consultant, but they don't realize that this is an umbrella catch-all term.
Yeah.
There's so much that legal nurse consultants do. You have life care planners, you have experts like me, you have IME observers, you have behind the scenes. There's a million different roles that LMCs can take. And even just looking at behind the scenes, that alone is another subculture because you have behind
Yeah.
the scenes independent, you have behind the scenes that work for insurance companies, for attorney offices, And you also have behind the scenes that help specifically with focus groups or deposition questions. And so there's a lot of niche aspects in LNC work. And so I always tell nurses that are interested in doing it, first off, make sure you've been a nurse long enough. At least 5 years is minimum. I recommend 10 or more. But make sure you've been a nurse for a while. If you can get certified, all the better. It just shows that you really value that nursing professionalism. And then do the work, investigate. Because what is legal nurse consulting without investigation? I mean, that's what we're doing. We're diving into these medical charts to pull out these details and make a whole story out of it. And so if you can't sit and investigate what legal nurse consulting is, maybe that's not the job for you.
No, that's really useful. And what has helped you the most? I mean, what's really bringing you the cases? And especially that you're doing so much, like you're speaking at conferences, you're writing articles, you're active on social media. So where would you rank these activities when it comes to, okay, this is something that you should focus on? Which one would you pick to be the most important aspect of getting your name out there and hopefully getting some leads from attorneys?
So I would first recommend getting involved with social media such as LinkedIn, and then also listservs. I think I've mentioned those a few times with you today, but there's several good listserv groups, and that alone can lead to obtaining some cases. Because while I am part of a few directories where I just pay to be listed on them, a lot of experts don't want to be listed. And so having a listserv like that or having a strong social media presence can kind of catch cases where the attorneys don't want a listed expert or where the expert just doesn't want to list themselves. It's a kind of a tight group as far as LNC work goes. And so even if you can manage only remote conferences, once a year, once every 2 years, I strongly recommend that just for the networking alone. Because just knowing those people, I can't tell you how many times I've had phone calls just to chat about cases, just to give a brief opinion and nothing paid. I'm not listed anywhere. They're not listed on me. We're just talking, oh, hey, does this sound normal to you? Or, hey, if you were in IR, would this have happened for you? Just to be able to have that group of people that you can lean back on. So networking is huge, not just with attorneys, because yes, attorneys help. And once you have repeat attorney client, that's very helpful. But having that network group of nurses gets a more diverse caseload.
That was really helpful. So Marilyn, thank you so much for being kind and generous with your time today. Given that it's been like a little late in the evening for you, and like taking the time to talking to us about all these things. I'm pretty sure attorneys who listen to this, legal nurses who listen to this, and experts who listen to this in general, like they'll all find this very useful. Before we wrap this up, is there anything that you would want to add to the conversation that I would have missed?
The only thing I would add is if you're ever thinking about doing a podcast, you are amazing. You're so very approachable behind the scenes. So thank you for that.
Oh, you're most welcome. The pleasure is all ours. And so if attorneys want to now reach out to you, what's the best way of doing that?
I still maintain my US phone number, but the quickest way, because sometimes the service gets a little sketchy, the quickest way to reach me is through email at mccullumlegal@gmail.com or through the website, which is the same.
Yeah, we'll add the link to the website and the email and the phone number in the show notes, so anybody who's listening can easily access that. So thank you so much once again, Marilyn, and I wish you the best in this new journey that you have, and hopefully we'll have you back on the show in a year or sooner to get updates on life in New Zealand and also how your ED flow thing is doing. I'd really love to see you take that to places.
Yeah, my newest project.
Yep. Thank you so much. Have a
Thank
great one.
you.
Bye-bye. Bye, everyone. If you found this podcast useful, remember to subscribe and give us a review on Spotify, Apple Podcast, YouTube, or wherever you listen to podcasts. This will help other users find this podcast and benefit from the insights shared by our guests. If you'd like to be featured as a guest on this show, please write to media@xlightum.com. See you in the next episode.